Hello, everyone. Welcome to the Axiom post-ASCO Town Hall for GI tumors. Thank you all for joining us today as we discuss the implications of data revealed at ASCO this past, recently. Today, Axiom welcomes, next slide, please. Today, Axiom welcomes Dr. Catenacci, medical oncologist and director of the gastrointestinal oncology program at the University of Chicago. We're also joined by Dr. Kasi, medical oncologist, clinical assistant professor of internal medicine at the University of Iowa Hospitals and Clinics. Next slide. During the town hall session, we will discuss some of the latest practice-changing developments across GI tumors. Topics in our discussion will include advances in the perioperative setting, first-line immuno-oncology agents in upper GI, followed by biomarker-driven strategies in upper GI, and finally, biomarker-driven studies in metastatic colorectal cancer. Please feel free to submit questions to the panelists through our Q&A feature throughout the session. And with that, I'll hand it over to Dr. Catenacci to begin the presentation.
Great, thank you. It's a pleasure to be here. And so we'll start off with this first Periop study, Checkmate 577. And this was updated presentation of the previous adjuvant study that was reported back in October at ESMO 2020. And so, again, this is the study design that many are familiar with at this point. Some key features are, again, that this included both adeno and squamous cells. This was for patients that had prior chemoradiation but residual disease, which we know is a poor prognostic factor, including, for the most part, node-positive disease after surgery. And another important thing to consider is that patients were R0 resection. They excluded patients who had a positive margin. And of course, patients had to otherwise be eligible and well enough to enroll postoperatively. Important stratification factor was a tumor cell PD-L1 expression, tumor cell, not combined positivity score, at 1% or more of cells versus none. And we learn in this abstract that most of this testing was done on surgical specimens as opposed to pre-neoadjuvant chemoradiation specimens. And then the primary endpoint was disease-free survival, which is a little unique with respect to most of the perioperative studies, if not all, that have preceded this study, which had a primary endpoint of overall survival. And we've seen these data before, which were presented again, showing an improvement in median disease-free survival in the intention to treat analysis, more than just about double the median disease-free survival. And you can see if these plateau curves, hold with longer follow-up, that there will be an approximate absolute benefit of about 10% in the nivolumab adjuvantly for a year versus surveillance, which was considered the previous standard. In terms of the forest plot subgroup analysis, you can see that this was basically shown previously, and that, again, as expected, squamous cell tend to do better than adenocarcinoma. And this was the first time that this was presented at a meeting. It was in a supplementary file of the New England Journal paper, showing that the CPS less than 5, so now combined positivity scoring, was significantly less than those that were above 5, and non-statistically significant with almost 300 patients in that group. And again, this still includes both histologies. So we still don't know what the subgroup analysis by histology by PD-L1 score, which I think is important to know going forward. Another thing that was reported at this meeting for the first time was the disease distant metastasis-free survival, which you can see the trend is very similar to the overall disease-free survival, suggesting that nivolumab has benefit on controlling metastatic disease as it is a systemic therapy, which would be consistent. And then they also presented quality of life data, which generally demonstrated there wasn't much difference in quality of life, maybe a little bit lower, trending to lower, but not statistically significant while getting nivolumab. And so that's the details of this particular abstract. And I just like to summarize here what we know so far from disease-free survival endpoint, from the intention to treat, and then by subgroups, but we don't really know yet by histology PD-L1, and of course we await longer follow-up for overall survival. So do you want to discuss some of the points?
I was going to say, I guess one theme which is pleasantly surprising theme for at least a lot of our upper GI malignancies has been a lot of the abstracts that we'll talk about have now an NCCN guideline and maybe an FDA approval as well. So this is one of the several that we'll talk about today that is now already endorsed in the guidelines and approved. Is this one thing that you're already doing for your patients, Dan?
Yeah, well, actually, that's a great question, and maybe a good segue to the next abstract, and then we can discuss, our strategies and what our thoughts are. But this is the neoageist abstract, which was the first time that this trial was presented at a meeting, and so this was a study of looking at a comparison of the two approaches considered options for G-junction esophagus adenocarcinoma tumors, which was either neoadjuvant chemoradiation with the cross regimen, as was most patients received in that previous abstract, Checkmate 577, or perioperative chemotherapy, and for the most part, as you'll see, mostly the MAGIC regimen. And so this study, which started several years ago, back in 2013, this was evaluating neoadjuvant chemoradiation, as you can see with cross in arm B, with a radiation level, which maybe we want to discuss at some point, of 41.4 gray, which was the original RT dose used in the cross study, the original cross study, versus the MAGIC regimen, as you can see here, some modifications of it, allowing either cisplatin or oxaliplatin, 5-FU or capecitabine for 3 cycles before and after surgery. This was the original study that was performed. And originally, the study was designed to show that cross was superior. But as time went on, and at interim analyses, this was not looking like it was going to be that different. There was a modification to decrease that amount and an increase in sample size. And then as we'll go to the next slide, we learned about the FLOT study, of course, that read out, which was a different perioperative therapy with different chemotherapy regimen compared to MAGIC, which was better. And so this amendment in June 2018 to the neoageist study allowed for this as a choice to be used. And so this is important. And in addition to that, because of how the data were looking, it was changed to a non-inferiority design, showing that these two arms were not substantially different from each other. And so again, we call it MAGIC, which is ECF and derivatives thereof that were used. Now, we don't know the breakdown of how many patients got each of these different subgroups, but we do know that was the majority of the patients on study. And this was demonstrating, I think, to summarize, that the chemo-RT arm, as might be expected, improved local control with path CR rates, R0 resection rates even, but that did not translate into survival benefit. Just looking at the subgroups here, you can see that, the majority of patients enrolled were MAGIC treated, and essentially this is MAGIC versus cross study. And of the patients who received chemotherapy, 85% went to surgery, and that's shown here, their postoperative complications. And of patients who got cross, 91% went to surgery and their postoperative complications. And there's no dramatic differences in outcome, but there is a trend to maybe increased ARDS in the cross arm. And so again, the outcomes here showed that there was really, after the second futility analysis, the recommendation was to stop accrual because it didn't seem that there was going to be any difference between these two approaches. And again, they're lumping in MAGIC and FLOT, but essentially this is a MAGIC therapy as far as I'm concerned. And so they're going to follow and continue at the final assessment in about 1 year. But the final summary was that there was no real difference, and that although there was some regional, as expected, complete response with radiation locally, that this did not translate into improved distant survival, distant metastatic disease and recurrence rates and overall survival. Again, I would change this to MAGIC, not just perioperative chemotherapy. And then to summarize here before we open up the discussion, looking at the sort of previous studies that had led to this with MAGIC versus surgery and CROSS versus surgery, each of them showing survival benefits. And then now with this NeoAegis study showing no real difference. And of course, the FLOT4 study comparing directly to MAGIC showing a benefit. We have an ongoing study called ESOPEC comparing these two groups. And if we do the math, really, you would expect that FLOT should be better than CROSS just based on this background, but we should await that study and see what it shows, because there could be different selection, different patients. But overall, we might expect that FLOT is better. And in my view, I'd love to hear Dr. Kazi's view, but my view is that when patients recur after surgery, they recur distantly. And so I think that's why we don't see local therapies that do better locally translate to survival benefit, because radiation doesn't affect micrometastatic disease, whereas a more potent systemic therapy like FLOT can enhance a cure rate to some degree distantly. And then to open it up, there are a number of ongoing studies that we await results for. We talked about the Checkmate 577 study because that's the first one of the immunotherapy-based studies to read out. But you can see there will be a whole bunch of other studies that we're going to be discussing over the next years as they read out, and how we're going to have to integrate this information to come up with what is the best options for patients. So now to get to the question that Dr. Kazi asked me is, what do I do? And I've also been pointing out the PDL1 scores for a reason, is that, I think that if there's really not much benefit from PD-L1, anti-PD-1 therapy in PD-L1 negative tumors with CROSS, and we know that FLOT, at least all evidence points towards better than CROSS, we have to keep that in mind. And in terms of the patients who are PD-L1 positive, yes, I think immunotherapy is going to be beneficial compared to not, but what is the best backbone, I think, is the question to ask going forward. And none of these studies really will be comparing that question, and we're going to have to piece it together from the outcomes of each of these studies. But I think the future is bright in the sense that we have some patients that definitely will derive benefit. And I think the work that we have cut out is to identify who those patients are.
And, the other paradigm shift that's happening, especially for bulky tumors, is the induction chemo before chemo adds. So Sloan Kettering, some of the other centers, and I know a lot of centers are adopting this in terms of induction regimen, whether it's a fluoropyrimidine-based doublet or even a triplet at outset of the chemo radiation.
Right, and the Top Gear study, which is ongoing and presumably nearly accrued, is essentially that question, because patients start with chemo and then they're randomized to having a component of neoadjuvant chemo RT or not, but they all get some chemo first. So that question is to some degree being asked with mostly, I think most patients will have had MAGIC, which is an obsolete regimen, of course, because this is an older study. And your point about CLGB 80803 is that, or 803 is that, that notion was that if they're not responding to induction therapy by PET, they would switch the chemo backbone. So yeah, I think there's a lot of variables that change along the way. And then I think both you and I are very interested in how ctDNA plays a role here in terms of helping us, dictate therapy pre-op and post-op. And I think that's all questions that need to be asked going forward. And hopefully that question will be at least as a parallel within these studies to see if that can help us identify who's really deriving benefit from these therapies.
One audience question, which is also relevant, and I think we've had some discussions about this topic too, for the Checkmate 577, the PD-L1 status, which tumor are we talking about? Is it just the baseline before the chemo adds, or is it the PD-L1 status post chemo radiation? Do you repeat PD-L1 expression? Do you remember, Dan, if the study answered that question? I know PD-L1 expression can potentially go up post chemo radiation.
It's a great question, and I think that was part of these set that we had predefined it. And so I mentioned, and it was in a footnote in one of the slides in the Checkmate 577 study from this meeting, that a PD-L1 was mostly tested on the surgical sample, so after the neoadjuvant chemoradiation component. I don't know the breakdown, but it just says most. And I think they took whatever they could get, basically. We do know that there are some reports now, 2 studies at least that I'm aware of. One was sort of a retrospective analysis by the same author, Ronan Kelly, looking at PD-L1 scores before and after and other inflammatory markers before and after chemoradiation. And there certainly was an uptick in some patients would have an inflamed response, which I guess is not surprising to anybody. But that was sort of an observational study. And in that study, importantly, they didn't show that these factors would predict benefit from chemoradiation alone. There was no immunotherapy in that retrospective analysis. But there's also a study called PERFECT, which is published in Clinical Cancer Research, which was using an immune anti-PD-L1 therapy with atezolizumab with chemoradiation, single-arm study. And it did show again that there is a group of patients that will have an increase in PD-L1 expression and gamma interferon from before and after biopsies. But they also showed that the only patients who derived benefit with path-CR and longer-term disease-free survival were those that were upregulated at baseline before they had anything. The ones who seemed to go up during therapy didn't seem to have benefit from at least anti-PD-L1 therapy. Now, small pilot study, but something to be aware of. And that's all we know at this point in terms of your question. And I think we need to really pay attention to these things and try and get that information on all of these future studies that are ongoing.
Another question that I think, Dan, if you go to your previous slide, you already kind of narrated that what would be the outcome if Nivo is added to the perioperative chemotherapy, and the FLOT Pembro study and some of the perioperative studies are ongoing. So that would read out in terms of immunotherapy pre-op.
Right. Yeah. So, the strategy of perioperative chemo before and after surgery with or without Pembro is Keynote 585, a huge study that's accrued and awaiting outcomes. Now, again, it's going to be plagued with this sort of confounder that most patients got cis 5FU because this was started before the FLOT4 study read out. And I'm aware of a smaller percentage, I think similar to the MAGIC study, MAGIC versus Cross neoadjuvant study I just presented. So it's going to be mostly the doublet with Pembro or not. And it'll leave us with the question is, what's the optimal with FLOT? Now, the Matterhorn study, which is ongoing in accrual, is durvalumab with or without FLOT. And we'll see what these answers are. And just to be sort of complete, we do have this adjuvant study, Attraction 5, going on in Asia with S1 or Kpox with or without Nivo adjuvantly. And so there are some smaller phase 2 studies, but whether these will proceed to phase 3, I think remains after we see the data from the phase 2.
This is probably more of a hypothetical question from one of the audience, but will come up as more patients get adjuvant nivolumab. How do you see exposure in the adjuvant study impact treatment upon relapse in these patients?
Yeah, no, that's an important one too. And it came up in these questions here. And so, I think that's uncharted water in the sense that, when typically, however we would consider this, say if this was chemotherapy with FLOT and the patient recurred relatively quickly after completion of that FLOT or even during, would we continue that? Of course not. We would switch to something else. We would switch to FOLFIRI or something like this with ramucirumab. But similarly, that's how I would approach this, is if they've recurred relatively quickly on nivolumab adjuvantly or any of the PD-1s on any of these study designs, then yes, we have first line data that it's beneficial, but that's in the setting of not having had it previously. And I think we don't know the answer to that question, but I think intuitively we would say if they've recurred relatively quickly, we would not. And if they recurred 3 years later, maybe I'd consider re-challenge with it.
Again, this is anecdotal, but we had a similar Big Ten clinical trial with adjuvant durvalumab with similar outcome measures. Some of the recurrence patterns appear to be different, and how this in the adjuvant setting plays out. I think we're still in the learning phase, and with all the new approvals in the first line, it would be very interesting in terms of choices. But no doubt about the benefit seen in the doubling of disease-free survival here.
Yes. Absolutely. So it'll be interesting and important to see the follow-up reports and the other subgroups, and of course, overall survival. That's another question, is this going to translate to a survival benefit, especially since we now know in the first line setting when patients either recur or when they're newly diagnosed, they derive benefit from immunotherapy at that point, and will that dilute out an overall survival benefit? Okay, well, that's perfect timing, and I think we can move on to the next set of abstracts, which was now in the first line setting, and one was an update and one was a new report, just like previous. And so the first one was the update by Marcus Muller and Checkmate 649. And again, just as a reminder of the study design, we see that this was a 3-arm study. In this case, all we know so far, including after this presentation, is the outcomes of the chemo with or without Nivo arm. We've not been shown yet the Nivo-Ipi alone arm. And so after a few iterations of the design, like for example, FOLFOX Nivo was not in the original study design, but now it was a main player. And also after changing the primary endpoints a few times up until the final primary endpoint, which was OS and PS and PD-L1 CPS greater than 5, and then a bunch of secondary endpoints. So we know now that we're showing in this abstract basically just the all-comers now, not just the ones above 5. And so you can see survival on the left and progression-free survival on the right, and you can see that these differences are somewhat attenuated compared to when it was selected for just the CPS above 5. And again, this forest plot, you should know when you're looking at this is different than the one at ESMO, and that's because this forest plot for the first time at ASCO is at all comers, whereas the forest plot in the previous presentation was for only those CPS above 5, which was, remember, the primary endpoint. And so you can see here, even though this is only tumor cell expression, that it does seem to differentiate benefit here. And you can remember that the hazard ratio was 0.75 in the original forest plot, and now it's 0.85 when you're starting to include all patients that were enrolled in the study. And then this was also new. Now it came out in the publication that as we're calling for to see these data, the CPS scores do seem to predict who's going to do well and who's not going to derive benefit from this therapy, at least in my opinion. You can see, for example, that CPS less than 5, which was the primary endpoint, showed basically the same median survival, hazard ratio 0.94, and not statistically significant. And those that were less than 1, again, hazard ratio 0.92 and not statistically significant. Similarly, we saw the same trends with PFS. And in fact, the chemotherapy arm was higher in the less than 5 compared to Nivo plus chemo, but of course, not statistically significant. And so to me, this is why we were asking for this, is because we want to know that information when we're trying to tell our patients what's best for them. And now down below, we also saw a response rate for the first time by CPS score. And you can see that there is an increase in response, single digit, not statistically significant, with hundreds of patients of 9%. But this doesn't translate to PFS or OS advantage. So you can see what my opinion is on that. Something else to note is that there was grade 3 or higher toxicity of less than 5% per organ category. But remember, the original report was that there was a 15% higher grade 3 treatment-related AE overall in the Nivo arm versus the control arm, which is why I make a point of saying we want to make sure we're giving it to the patients who are actually deriving some sort of benefit. Shall we discuss or go through Checkmate 648? Are there any questions?
I think we can continue.
All right, so then this was the first report of Checkmate 648 that came out, the sort of companion study, but now the same design, but for squamous cell only, as opposed to the previous study was for adenocarcinomas only, including esophageal adenocarcinoma down to the stomach. This study was squamous cell only. And again, you can see otherwise the study design is quite similar. The primary endpoint was survival in PD-L1 greater than 1%. And so we see the statistical hierarchy here, which is common in these new age studies where, if you check your primary endpoint, and then if it's made, you can then proceed to the remaining all-comer group. And so that was the case in this study. You can see that comparing the 3 arms in this study, you'll note that the data for nivo-ipi are being shown, as opposed to Checkmate 649, who was reported first, still not shown yet. And you can see the median duration of treatment in each arm was the longest on nivo and chemo, and 55% of patients received subsequent treatment, and the predominant treatment was chemo, although the chemo arm here did 16% received IO or nivo-containing arms later, whereas the 2 nivo-containing arms got 5% received nivo-containing arms later. And so comparing first just the nivo-chemo versus chemo comparison, we see here on the left, the primary endpoint above 1% tumor cell staining, not CPS, tumor cells, and on the right, all randomized. And we see that same phenomenon again of the dilutional effect when adding in, all comers. And in fact, that seems to be not much different from each other, although the hazard ratio is better because it's taking into account the whole curve. And the overall survival, again, the same phenomenon where there's a striking benefit in the PD-L1 TPS higher than 1, whereas all comers attenuated. And so again, raises the question of what do those patients that are less than 1 actually look like individually? And then of patients who derived a response, you can see that the median duration of response is longer, and that there may be a slight uptick on the tail of the curve with those who are about at 1% or higher. And similarly, maybe in the group that's lower, although this is including these same patients, right? We're not seeing these curves with the individual less than 1. And then the subgroup analysis, the forest plot, again, to point out this is for TPS, not CPS. And here it does seem where usually TPS is not that predictive. In this study, it seems to be quite predictive. And so, of course, if we were to see this by CPS, which hopefully we do someday, might show that difference even more accentuated. Then going on then to the nivo-ipi versus chemo comparison, we see that with a chemo-free arm, we've seen this in every study in gastroesophageal cancers, this yin-yang effect where there's some patients who do worse and then some that do better. And certainly that yin part of the yin-yang curve is accentuated once you add in patients with low PD-L1 scoring, which is the concern here. And then overall survival, the exact same phenomenon. So again, the duration of response of patients who actually get a response from this therapy, which you can see are subsets of the whole, seem to be better, which is expected with immunotherapy studies. And this is all sort of attenuated as usual when you add in all comers as opposed to PD-L1 selected. And again, as expected, PD-L1 does predict benefit, and TPS, somewhat surprisingly, starkly showing some differences here, where, for example, in the primary endpoint of this study, less than 1%, there's absolutely no difference. And this is 330 patients, right, in the first-line setting squamous cell. For adverse events, you can see that nivo plus chemo has about a 10% higher or 11% higher grade 3 or higher toxicity. Nivo-ipi, which is a concern for toxicities, has about a similar, but within 5% range of toxicities compared to chemotherapy. And so this is their summary here, and we can maybe move on to these questions and any others that the panel or attendees have.
One of the questions that came up regarding the previous nivolumab study is, why was the approval in all comers then, if there were predefined PD-L1 subsets?
Yeah, I cannot answer that question. I wonder if you can, Dr. Kazi. I don't know the answer. It seems pretty clear that that there's not any benefit there. So I'm not sure why that answer. In fact, you may know that the NCCN guidelines had it. I haven't seen it lately, if it has changed, but had the recommendations at the original primary endpoint of CPS 5 or higher based on Checkmate 649's primary endpoint.
I guess the only rationale that comes to mind is, as we know, PD-L1 is not necessarily the best of markers. So the question is, do you preclude the benefit of the doubt in these circumstances to the patients who could get immunotherapy? I don't know, but I would imagine that the approval should be in alignment with whatever the trial eligibility cutoff was.
Right. Yeah, no, I've heard that argument. And I mean, it's not a perfect biomarker, but there is no perfect biomarker. I think that even if you looked at HER2 as a biomarker, it's been through the same sort of story. And what should the cutoff be, and this and that. And so in the end, every study that we've seen has shown the same thing, that patients that are certainly low, less than 5 is low, 5 on a scale of 0 to infinity or 100 is low. And so I think you're cutting it low for that reason, as you just mentioned, that you don't want to miss some patients. But in every study we've seen, those below those levels aren't deriving any benefit, but they are experiencing the same toxicity rates. And that's what's concerning to me. And we haven't even talked about the cost of the therapy.
What do you feel about the CTLA-4 anti-PD-1 ipi-nivo combo? There were some slides at the ASCO regarding that this subset had of the ones who responded, I guess the duration of response, not surprisingly, to some of these IO combination, it was the highest in this subset. Again, we're looking into subset analyses, but that was one thing that I saw at the meeting that was talked about.
Yeah, no, I think that's an important one. And so, what concerns me about the Nivo-Ipi, like any chemo-free approach, is that if you get it wrong, you're actually doing harm, because you're removing the chemo part, which we know has benefit, and we see that in the yin-yang curves. And the yin-yang is definitely accentuated, as I pointed out, in the low-level PD-L1 group. So if you're going to do this, you want to make sure it's in patients who have, some chance of being on the far end of that curve, and minimize the patients that are likely to be on the left side. And the things that we know that would minimize people on the left side are minimal disease burden, minimal symptoms, great performance status of 0, and high PD-L1. Those are the things we know. And so maybe, but then the question here to me in this study is, what is the addition of Ipi providing here without a Nivo versus Nivo-Ipi comparison? I don't know what this means. And so these are the, from a critical standpoint, from the patient's perspective and the payer, that's the question that needs to be answered.
And again, just to echo the theme again, these were also FDA approved now for pembrolizumab as well as nivolumab. So in addition to NCCN guidelines, now you have FDA approvals as well for these chemo IO combinations in the first line setting.
That's right.
Correct me, is the ipi-nivo? I don't believe so. It's in the guidelines yet. I think people are still trying to analyze and wait for long-term data.
This is fresh off the press here as of ASCO a few weeks ago. I have not seen the most recent, NCCN guidelines yet, and what they will do. Because remember, they kept it at the cutoff based on Checkmate 649. So for 648, I'm not sure if that's even in the guidelines yet. I'd have to look myself and what the specifications are.
Got it. I think maybe we can move to the next slide and continue the discussion. Some of the ongoing immuno-chemo combination, but moving on to some biomarker-driven studies. The first one is the Keynote 811, which is from Dr. Janjingian from Sloan Kettering. This was anti-PD-1 pembrolizumab with chemo with anti-HER2 trastuzumab in patients who are HER2 positive. There have been several phase 2 studies, not just with pembrolizumab, but other IO, anti-HER2, anti-PD-1 combination, going back to the question that maybe anti-HER2 was the first immunotherapy ever invented, because it seems like trastuzumab does more than just anti-HER2 activity as a monoclonal antibody. It potentially may recruit TILs. It probably leads to some antigen presentation. So there are many preclinical rationale that led to this combination being investigated initially in terms of safety. At ASCO GI, I believe it was 2018 or 2019, these results were already presented, leading to you can see from the small waterfall plot, which kind of speaks for itself, there was disease control rate of 100% and 91% overall response rate in the first line setting, as well as some other similar studies that we also did as part of the Big Ten and other groups in Asia that corroborated the same, leading to this large global cohort, essentially asking the question of the addition of anti-PD-1 to the first line trastuzumab and chemotherapy approach. There was a placebo as well. So next slide. Again, not to go into too much detail, but both the pembro and the placebo arms were balanced between the two arms. This was efficacy results in the first 260 patients that were enrolled. Pretty much from what we know, at least biomarker, and we can talk more about in the panel discussion as well, is it seems like, at least overall, when we look at these subsets, you have the MSI subset, then you have the EBV positive subset, then you have the HER2 subset, and we'll also talk about the FGFR subset. It seems like there are most of the times mutually exclusive, but as you can see here as well in the PD-L1, they tend to be more so PD-L1 positive, at least the CPS cutoff of 1. As you can see, most of these tumors were positive, kind of going back to maybe an additional preclinical rationale to combining it with anti-PD-1 regimen. Next slide. Again, the results kind of speak for itself. The disease, the study met its primary endpoint. There was, as you can notice here, 74% overall response rate compared to, in the placebo arm, this was an additional 22.7% improvement in response. And Dan can allude to this as well. You know, some of our patients in the first line upper GI malignancies, while sometimes we always talk about if the study was important, if it led to overall survival difference or not. In upper GI malignancies, response can be a key variable. So I would not necessarily, first of all, this is impressive on its own accord, but response can be a key variable in some of these patients who are symptomatic from upper GI malignancies. Next slide, please. And again, we are very much familiar with the addition of IO to chemo backbone. The trastuzumab doesn't add anything different in terms of toxicities. So the toxicity noted here is very similar to the several studies that Dan presented earlier, and also some of the other readout. There were no different AEs that one needs to be aware of in this particular setting. Next slide. So in summary, this is something that had been incorporated in the NCCN guidelines a few months ago, and now also got approval as well. As this chemo backbone was with CAPOX, the every 3-week regimen. Pretty much now, the every 6-week pembrolizumab can be replaced, and that goes for nivolumab as well. The Q4 can be replaced for any indication for which there's a Q2-week approval. I don't believe the approval dictates that you use CAPOX. I would say a lot of the centers in the country use FOLFOX as the preferred backbone. Do you have the same practice, Dan, on this abstract?
Yeah, I do. I use FOLFOX usually for the most part in our patients. Many of our patients with G junction esophagus cancers can't swallow pills very well at diagnosis, and so FOLFOX is preferred and overall probably better tolerated. We actually drop the bolus. We don't include the bolus to improve tolerability in this late line setting. So yeah, I think oxaliplatin is definitely preferred chemotherapy versus cisplatin. And go ahead.
I was going to say, one of the audience also alluded to the fact that these tumors were PD-L1 positive and the duration of response wasn't too different. If that's anything concerning, I think right now I would say the OS and some of the other data is still maturing, but it definitely seems like these patients are deriving benefit. Now, there could be other mechanisms of resistance to HER2 blockade that may be overcoming any of the IO effects, and it's becoming a very crowded space in terms of HER2 drugs, and we'll talk about one in the context of colorectal cancer in one of the Destiny trials, but that would apply to the HER2 positive upper GI malignancies as well.
Yeah, no, I think it's a great question. And, we're seeing unprecedented times with these types of approvals, like a first-line study now being approved conditionally, but approved based on just a response rate in a randomized phase 2 study. So, of course, that's going to be conditional on the phase 3 readout, which is a primary endpoint of survival, right? So when we will see that might be some time, obviously, because that's a longer readout. But in the meantime, this is, a 22% increase in response rate. You saw the waterfall plot. Whether that's going to translate into improved PFS and disease control rate, because many of those patients who didn't have a response on the control arm were disease control, right? And so in the end, that's what we really care about for the most part. Even those patients who have disease control often have symptom improvement. So whether that's going to translate is a question I think we have to wait to see. But in the meantime, it's an option for me. You pointed out about PD-L1. And most of these patients are PD-L1, at least by the low cutoff of 1. I think we're really going to want to call for the outcomes by PD-L1 score to really see if there's any benefit, just like every other study, or not, because maybe there's a different interaction here with HER2 and trastuzumab, or maybe not. But how are we going to know unless we look and see the data? Those would be my inputs, but other than that, I agree with everything.
And this is somewhat anecdotal. We had a very similar backbone study with our Big Ten cooperative group, which was an anti-PD-L1 avelumab, but again, essentially the same combination with FOLFOX instead of the CAPOX and trastuzumab. We presented phase 2 results at the AACR meeting this year. One observation now, again, going back to the PFS question, you could progress where you already had lesions to begin with, or you could progress at new sites.
Right.
One thing that's very intriguing about these targeted therapies is, we've seen some patients with innumerable liver metastases where everything disappeared, but then something new popped up in the lung. So, while you had disease control, even to the point of PR and CR, and that's evident by the waterfall plots in the slides earlier, you could essentially meet criteria for progression having one lesion that may not be clinically concerning, and you could always radiate that in real practice, but obviously in the trial that still counts as a progression. The person has to come off of study. But with all these new target therapies, the patterns of progression and also the ability to maybe use local regional to kind of keep the mileage going is also an intriguing observation, not just for this study, but across other targeted therapies that have a deep response and progression later.
I completely agree. And many times that's a HER2 negative subclone that's growing. And like you point out, if it's just one little spot and the rest of disease is controlled, we often target that spot with a locally ablative therapy and then continue on the systemic control that was keeping everything else at bay. Yep, for sure.
And again, this is still pretty much exploratory, but I think this is where the value of repeat analysis, whether it's tissue or liquid, to see if the HER2 expression is retained. Are there acquired mechanism of resistance that would potentially be overcome by a TKI like tucatinib and some of the ongoing studies, or is it something that has retained expression where something like trastuzumab deruxtecan could still be approved in second-line setting after patients who fail this particular regimen?
Right.
We can probably go on to the next study. And again, just to point it out, Dan Katnagi is one of the investigators, and he presented the study, so I'd not steal the thunder from him, but essentially kind of going over the slides here. This was a first-line study here, again, keeping the biomarker-driven approach, advances for our patients in GI malignancies and other tumor types is coming in subsets. And this is not an uncommon subset. Interestingly, it seems like about 30% of upper GI malignancies were positive for FGFR2 beta, and this was based on an IHC. The study also had FGFR2 gene amplification as the eligibility criteria shown here in the box, and we'll talk about that in the results, but apparently that wasn't as high. It's about 2% or so. And again, these were patients who were not HER2 positive. Dan, while you run this question, is this something that is mutually exclusive, or did you have patients that you screened for this study that were HER2 positive?
Yeah, it's a great question. And generally, these tumors, the amplified tumors, whether it be HER2 or FGFR2, or there's others like EGFR and MET, they cluster in that TCGA subgroup, the CIN group, the chromosomal unstable group. And For the most part, they're exclusive, but not always, and they often co-occur. Now, in this eligibility, you see that HER2 positivity, if it was known, was excluded. But because this was a global study, in some places where trastuzumab is not available, they don't even check for it. And so there were potentially some patients enrolled that were HER2 positive, just wasn't known. There was no central confirmation of that. We saw that with the ctDNA analysis, which was mandatory in all patients, where some patients were both FGFR2 positive, either by ctDNA or by IHC, as you're going to go through, and ctDNA positive for HER2, but that wasn't an exclusion criterion because that came back after the fact.
And going on to the next slide, just to kind of go over the study schema, as you can see in the 910 patient screen, 30%, this is not a small subset, almost as high as our upper GI HER2 malignancies. And again, this was immunohistochemistry tests, although they did allow for gene amplification. Up to 4% of these patients were positive on ctDNA. And then these were assigned to receiving, again, chemotherapy backbone with FOLFOX, with or without either the bemarituzumab or the BEMA or the placebo. We can go on to the next slide. And again, in terms of efficacy in the forest plot and what we see, the benefit was retained across the different categories of interest. And I think here it does say that the median survival wasn't reached, but I think on the longer follow-up, as it evident on the next slide, if we can go, it did talk about almost a 5.7-month improvement in the median overall survival. So it is obviously statistically significant as well as clinically meaningful. Any thoughts on this, Dan, while we're on the efficacy analysis of this drug?
Yeah, I mean, I think this is pretty impressive with a median follow-up of more than a year, and we're seeing these types of differences from all comers. And then, when we increase, so just to make sure everyone's clear, like the intention to treat, you were positive with either ctDNA positivity for FGFR2 gene amplification and or one or both of IHC at any tumor cell extensity. So less than 1% of cells could have it as long as it was 2+ or higher intensity was the intention to treat. And that was the 30% incident positivity rate. But if you made it a little bit more stringent, the criteria of what's positive to 5% of cells staining at 2+ or higher, then you do start to see even an accentuation of the benefit. And certainly at 10% of cells or higher, it's even more pronounced, where, that's pretty remarkable. And whether that's going to hold with longer follow-up is, we'll see. But for now, it's really impressive. And again, just like we see with all of these biomarker studies, if you're going to super select, then what's going on with the residual ones, like less than 10? And so we don't know that. But you can imagine by math that it's not as good, right? Because this is the whole, and this is just looking at the ones above. So what's the optimal cutoff, I think, needs to be debated. And these studies are going to be ongoing in the future as phase 3 studies.
And just going to give a perspective, in the HER2 negative space, now again, there are probably some patients who had an overlap, but this was an exclusion by study design. Reaching anything above a year in terms of survival with some of the IO combination was a huge milestone. Again, from a patient perspective, we still have a long way to go, but to see anything upwards of a year, it was something that has been encouraging, at least in the last year or so. And you're noticing here, again, by biomarker selection, upwards of 19, 25, or not even reached subsets. So definitely clinically meaningful outcomes here.
Yeah, and I think you're pointing out some things that are going to be coming along the way now are going to be in patients newly diagnosed. There's going to be a choice for therapies now, and which is great. I mean, looking back 10 years ago, we had FOLFOX, and now it's, if you're HER2 positive, FGFR2 positive, PD-L1 positive, MSI high, and maybe Claudin, another one on the way. And then if you have overlapping of some of these biomarkers, how are you going to decide? And I think we're going to need to prioritize, what are the outcomes with each of these individual groups and give them their best shot.
And moving on to the AE, just to kind of highlight, there are some peculiar AEs, and some of that is, in some ways, even though this is a different drug compared to some of the FGFR fusion inhibitors, you see the pattern of ocular toxicities that are important, and goes without saying that a lot of these new targeted therapies, ophthalmology eval at baseline and at times of any symptoms, is going to be a practical consideration to keep in mind.
Yep.
So pretty much, at the median follow-up of 12 and a half months, we're looking at 19.2 versus 13.5 months with longer follow-up waited. Do you know, Dan, in terms of both in terms of guideline endorsement or FDA approval, is that something that has been already taken to the FDA or under consideration for use? Because, obviously the results are, and also maybe you can speak to the testing part. Again, this was FGFR2 testing that was done as part of the trial. Is that something that labs can do?
These are all important questions. And so I think it's a little bit of a unique situation in the sense that the previous, this would be probably a conditional approval if it was going to happen. But in this case, it's a new therapy that's not commercialized in any other indication yet. And it would be a new biomarker assay that's not commercialized in any situation yet. And so that would be yet another unprecedented approval by the FDA if it was to be done. In terms of whether that's actually in process, I don't know the answer, frankly. But you can imagine that, the response rate here, at least in the 10% expressors or higher, was 18% difference, which is pretty similar to 22%, which already got an approval for Pembro for HER2 positives. And this has survival data. The other one didn't. And the survival data is like the best we've ever seen in any study to date. So if you're going to make an argument, I guess you have to be consistent, I would imagine, but we'll see what happens with that going forward. But there are phase 3 studies being planned, obviously, as I mentioned, and that's on the bottom of this slide.
You probably enrolled some of the patients to this trial, going along the toxicity management, from the ocular AEs. I imagine, hand-in-hand collaboration with any of the ophthalmology, whether it's community or academic, is key. The stomatitis, was that anything out of the ordinary than the usual Folfox neutropenia, or is that something that has different management?
Yeah, no, I think that the stomatitis first, it was, a little surprising to us to see that because, in the monotherapy studies before, we didn't really see that. And it reminds me a little bit of like the Regard and Rainbow studies where stomatitis was accentuated with ramucirumab when added with paclitaxel, but it was otherwise managed similarly to other mucositis. With the AEs of the ocular things, that's one that we're going to have to pay attention to. And on the study, we knew that was potential because it was a monotherapy issue in late line as well. Not common, but we saw it. And we think that it's an on-target off-cancer effect. So in the eye, the target is there in the cornea. And we did report here in this abstract that the median time to onset of grade 2 or higher was quite long, like it was like 24 weeks. So, and the median time to resolution to grade 1 or lower was also long, like 18 weeks or something like that. So in other words, there was no prophylactic measures done here other than sort of free, visits every couple of months with an ophthalmologist. So here, going forward, I think like in that phase 3 study noted there that they're going to be doing some preemptive prophylactic approaches to see if that can help mitigate this issue. But it is something we need to pay attention to. But I'll contrast this drug, which is an FGFR2 antibody, to other FGFR inhibitors out there, which are TKIs for the most part, for bladder cancer, cholangio, et cetera. And their toxicity profiles are quite different, where they have more electrolyte imbalances, they have retinal issues in the back of the eye, and many of these things are probably thought to be on off-target, like non-FGFR2, but other FGF receptors and other splices, variants of FGFR2 potentially. So I think it's an important thing to consider, though, with respect to the corneal toxicity.
And moving on to the next theme on the subset biomarker-driven cohorts. Next slide. It's the updated results from Keynote 177, which led to the FDA approval of Pembro in the first-line setting for mismatch repair deficient colorectal cancer. I think a lot of us are familiar with the study design and the survival, and we can go on to a couple of slides down where we see the PFS and PFS2 curves. And as not surprisingly, the immunotherapy arm in these MSI high subset, which is a different beast altogether, doesn't matter if it's colorectal, upper GI, other tumor types. For many biological reasons, chemotherapy doesn't work for them. Now, we still are trying to understand who are a third of these patients who have the initial crossover the curves, who don't respond to IO, who may be potentially suited for other chemoimmuno regimens or maybe dual immune checkpoint blockade. There is the ongoing COMMIT study, which is studying atezolizumab, single agent immunotherapy versus chemo, anti-VEGF, and immuno added. But going on to the next slide, which was the updated survival analysis, you can see the difference, but the difference is somewhat blunted. And just to point out to the audience, if we go to the next slide, if we count the number of patients, this had crossover. So any study that has crossover, narrowing it down to overall survival analysis, you have to know how many patients did crossover. So officially, about 36% of the patients crossed over, but also unofficially, another 37 patients, as you can see, received anti-PD-1, PD-L1, mismatch repair deficient, agnostic pembro approval across the US has been there for a while. And knowing the benefit that's seen in some of these patients have a brisk, durable, ongoing responses, to the point I think this is one situation where I've heard a lot of GI oncologists, regardless of this is colorectal MSI or upper GI MSI, if you do respond and if you continue to respond, this is the place where I've seen oncologists use the word cure. And going back to the previous slide, if we just look at it one more time, you see this flat plateau in these MSI high IO studies that is unprecedented and not seen in other tumor types. So going back to the next slide again, you have 60% crossover that happened in this study. So that has to be kept in mind when you're looking at survival analyses. Any thoughts on, I think pembrolizumab MSI high first line is here to say.
I think there's a question here for you. What's your preferred option then at this point? Is it pembro, or is it a combination of an anti-PD-1, whether it be pembro or nivo with a CTLA-4 inhibitor like Ipi? Is it, you mentioned chemo plus, say pembro, because we don't have that in that third arm would have been an important one, I would imagine, in this study to see if we could mitigate that detriment, maybe, and accentuate the benefit in those quick progressors. What do you think?
Yeah, so as of right now, what's impressive is the dual immune checkpoint blockade with the CTLA-4 addition, the AP-NIVO studies, they do have deeper responses, and it seems like based on, again, something that we're not supposed to do, cross-trial comparisons, some of the experts argue that maybe you're getting deeper responses and maybe the survival outcomes potentially could be better in terms of PFS. However, I would say at this point in time, for the ones that even respond to single agent anti-PD-1, I won't necessarily expose them to dual checkpoint blockade. It kind of goes back to what you were arguing earlier. If you have a patient with high burden disease, you don't want to be wrong. In somebody with young onset MSI high cancer with a bulky disease, maybe that's the only situation I can think of where I may go for dual checkpoint blockade. But other than that, standard of care for most, if not all, patients is going to be single agent anti-PD-1, with a reminder I would still accrue that patient to the COMMIT study, which would help us answer the question of who are these, 30% patients, a third of patients who didn't respond to single agent anti-PD-1, where we will know the answer if the addition of chemo, anti-VEGF to anti-PD-1, PD-L1 blockade is going to help mitigate that.
What do you think about the RAS mutant stuff? Is that something that you think is important to keep following, looking forward, and see, is that the patient group that might be the ones you could predict aren't going to benefit from the monotherapy?
With the patients that immensely benefit right now, I don't think we can use any of the markers as a predictive biomarker, because these are all exploratory subsets. Most people thought that maybe the BRAF mutants may not drive as much benefit, and some of the exploratory studies from single centers have alluded to that fact too. I think this is all exploratory subset analysis. At this point in time, the only data that I've seen that maybe somewhat reflects to that there might be value for the TMB cutoffs, and work from Dr. Fakih and his group has looked into TMB cutoffs of 40 or below versus anybody with 40 or above as maybe an additional subset that may derive benefit or not. These MSI high subsets are the same subset that are also enriched in NTRK fusion. So if you have a patient like that, do you select an IO versus NTRK fusion? I think right now, I would say the conclusion is there's no predictive marker to suggest who would or won't derive benefit from anti-PD-1 single agent. And with the side effects profile being so manageable and low, it would be the standard of care for anybody presenting first-line MSI high unless you have a trial.
Yeah. I have one more question. So if you had an oligomet MSI high and you had a great response, but you still had some residual sort of scar tissue, say in the liver, I know that you have some opinions on this. What would you recommend in terms of, curative intent surgery in that setting compared to an MSS patient?
What's surprising is there's a paper published by our groups from MD Anderson, and they reported on 14 patients at their institution who got salvage surgeries because of residual radiographic disease, and this is published, and they had a follow-up analysis as well. Of the 14 patients who got surgeries, 13 out of 14 had complete PAT CRs. So residual radiographic disease in these mucinous MSI high tumors is not uncommon. Before subjecting a person to any kind of surgery, I would argue that if you look, and this is just one paper, and I have folks who follow us on social media, I have a thread on this. I would have compiled at least 6 or 7 more papers where there's a paper from Dr. Eng and colleagues from Vanderbilt that looked at rectal cancer patients who got IO either off-label or as part of their care for rectal cancer neoadjuvant therapies. And of the 3 that they reported on, because rectal MSI is a rare entity, 2 of them declined surgery because they didn't want to end up with an ostomy, and they're still disease-free, no progression. And the third one, who ended up getting a bilateral salpingo-oophorectomy, hysterectomy, you name it, the whole quote-unquote curative intent surgery, there was no tumor found. And there's a series from Japan, series from other courts. MSI high patients who respond, residual radiographic disease, I would pursue a biopsy. I might consider a PET scan. This is one situation where at SITC, we talked about maybe using some of these MRD assays to see and maybe spare the person a surgery if not needed. It's kind of boils down to that. I think MSI high and with better efficacious therapies, potentially would become a disease where surgery may not be needed anymore.
I completely agree with you. That's why I asked that question.
And then finally, another subset, another novel drug and some unique toxicities that to go over with Destiny is a series of studies done with this novel agent trastuzumab deruxtecan, which is an antibody drug conjugate that has a similar to irinotecan, a topoisomerase linker attached to it. In this particular study, again, the paper has been published in Lancet as well, so there is more details that the audience can look at. But it boiled down to the subset of colorectal cancer patients who had HER2 positivity. One important clinical consideration is who are these HER2 positive patients? They tend to be more rectal and distal colon. So if you had to look at numbers who are positive and which patient you definitely don't want to miss HER2 checking at baseline, are these rectal and distal tumors. And the numbers, it's interesting, there's a meta-analysis published. Patients, this is also a phenomenon acquired post-EGFR in the RAS-RAF wild-type left-sided cancer patients. So if you look at some of the numbers of percentage HER2 positive post-EGFR expression, it goes up to double digits. I've seen some series as high as in the 20s as well. So it's one of those markers that you want to recheck after exposure to anti-EGFR therapies in the RAS-RAF wild-type left-sided cancers. Next slide. Again, looking at response rate, we can look at the waterfall plot, which is shown on the next slide, to kind of show you that these are very efficacious drugs. Most of these patients respond, and there's something to be said about the IHC positivity. As you can imagine, you need the IHC or the cell membrane receptor to be able to deliver the drug and be able to deliver the chemotherapy internally to these tumor cells. And speaking to kind of some of the discussion that we had earlier regarding predictive biomarkers, PD-L1, HER2 is also, far from being a perfect biomarker. And not surprisingly, what is IHC plus 2 plus? Is it following the breast criteria, gastric criteria? It's a question that keeps coming back and forth. Thoughts on the marker?
Yeah, I think you nailed it right there, and that this is a classic example of like what's the perfect cutoff. And I was going to ask you first, actually, what are your thoughts on, because there was a lot of talk about this being effective not only in amplified setting but in non-amplified setting low expressors. And do you think that that's met its mark, or there's like no responses in these groups?
And again, I'm not a breast oncologist. It seems like at least in the breast cohort, you see more benefit. So you were seeing some hint of a benefit, but if you look at the numbers in terms of responders and the PFS, OS, in the ones who were not meeting the cutoff, especially the low ones, I think they had even closed the arm because of lack of futility. So because of futility, so at least in the CRC cohort, I don't think we can say that. And then going on to the next slide, it kind of, at least when we look at the toxicity, this is going back to the HER2 expression. Not surprisingly, you see in the forest plot, the left-handedness of the IHC2 plus or the 3 plus ish positive patients who derive more benefit. So at least for now, based on this analysis, it's the high expressors who are driving benefit. And going back to the toxicities that are important to kind of keep in mind is this interstitial lung disease or pneumonitis that can be seen. And it's important to keep in mind it's different from the pneumonitis that we see in anti-PD-1 or other allergic reaction-based pneumonitis. This is more so a cumulative dose-dependent phenomenon, kind of like bleo toxicity for those of us who have been using that drug in the past. The other thing to kind of keep in mind is from the mechanistic standpoint, Kohei Sutara and his colleagues have looked into this, and in some of the chimpanzee studies, it seems like it's recruitment of alveolar macrophages in the lungs. So, one question that often comes up is with all these anti-PD-1 drugs getting approved, and people are also talking about combination with anti-PD-1 with maybe this TDXT or DS8201, would you see more patients developing these severe toxicity? Because some of them are grade 5 events. The grade 5 patients, it's death on the study. So obviously not something subtle. It is something important. I'm not sure if it's preventable. At least it's predictable, where it's a cumulative dose-dependent phenomenon, and it didn't happen right away. But at the same time, I've seen patients where it just creeps up on you. So as you have all these different HER2 therapies be available, risk-benefit ratio would have to be individualized for each patient.
There's a question here. How do you explain the difference in efficacy in HER2 low expressors in colon versus gastric?
I think some of that is probably the heterogeneity, and especially for colorectal as opposed to gastric. I think the gastric low expressors, there is baseline HER2 expression upwards of a third of these patients. Colorectal, the baseline expression is only for 2 to 4%. So on the trial, I don't think I was able to discern if these were patients who were HER2 truly positive at the baseline tissue from get-go, like the rectal cancer patients, or were these patients who had acquired HER2 expression? And you could argue there's so much heterogeneity. It is possible that entry point study biopsy was positive for HER2 in the colorectal cohort, but maybe they were HER2 negative at other sites. We don't know that question, and that's where the other question that often comes up is, can we use circulatory biomarkers to detect HER2 ERBB2 amplification as a marker? I think these are all exploratory questions.
Yeah, I agree with you. But in the end, I think I don't think there have been data for gastric for FISH negative low expressors, at least that I'm aware of. But if the question is for low expressing ISH positives, then that also showed a very similar thing, in the sense that the ones that were ISH positive 2+ for gastric, if you look at the forest plot in a New England Journal supplementary file, it's on the line. It's like no benefit in those patients, but it's all derived from the 3+ patients. So I don't think there's much difference there at all, actually, in the end. But all right.
And one, again, which is the theme, which is pleasantly surprising, is that some of these drugs have been included in the guidelines way before some of these results came out. So trastuzumab deruxtecan for colorectal is included in the guidelines, and so is pertuzumab, trastuzumab, as well as lapatinib, trastuzumab from the Heracles study. So it is one of those things where I think as a GI oncologist, I have to keep reminding myself to look at the guidelines again, because some of the guideline endorsements, which is important for getting access to some of these drugs outside of trials for some of our patients, if it's guideline approved, you can get coverage for these drugs, and it is included in the NCCN guidelines for colorectal cancer.
Let's see. So, I think we talked a little bit about the Keynote 177 and what's the standard, but based on Destiny and all the other options that we have now, what do you do in terms of how do you stratify and decide which one of these things? Is it lapatinib, trastuzumab based on Heracles? Is it pertuzumab, trastuzumab based on a couple of different studies? Or is it trastuzumab deruxtecan based on this Destiny cohort? You mentioned, I think, the tucatinib and trastuzumab approach with the Mountaineer approach. So which ones do you choose first, and how do you sequence them, or do we even know?
So the short answer is clinical trial is always going to be the right answer. And I can, at least for the purpose of the United States, most centers have some sort of ongoing HER2-based trial. So, and it's also important, some of the trials, if you did off-label or just prescribe somebody lapatinib, trastuzumab, you may render them ineligible for, let's say, the Mountaineer ongoing study or the other ongoing studies with these novel molecules. So, and there's also a cooperative group study with Dr. Eng and colleagues that is looking at anti-EGFR versus anti-HER2, because the other role of HER2 is being a negative predictive marker in terms of response to anti-EGFR. So there are important questions that need to be answered still. So both community as well as academic oncologists, we need to enroll in ongoing studies. Now, going back to the efficacy slide, if you could, a couple of slides ago, one important point to remember is, these are patients who are highly refractory, multiple lines of therapy. Some of them were up to like 6 lines of therapy. With all the different tools in our toolbox, and also rising incidence of colorectal cancer in the young patient population, a median overall survival of 15 plus months. Again, this is a good problem that we have options. I think looking at the risks and benefits and the side effect profile, right now, at least, the grade 5 events is still, a single percentage digit, and it's something that we need to monitor, but doesn't preclude the use of these agents in the highly refractory patient population. I think you won't go wrong with any of the approaches. However, I might put lapatinib and trastuzumab, the Heracles study, and the numbers lower on my list unless I can't get my hands on the My Pathway combination with trastuzumab, pertuzumab, a trial, the Mountaineer study, or trastuzumab deruxtecan as shown here. So short answer, there is going to be a trial somewhere close to you, so enroll in the trial, because some of the accrual to ongoing cooperative group studies has slowed down since the endorsement by NCCN guidelines of some of these regimens. So it's a double-edged sword to sometimes get these approvals ahead of time.
Right. So what do you think the potential is then to move this agent to TDXD or others, the other combination that we just talked about earlier, even to first line? Why wait?
Especially I know for at least in the with the tucatinib, there are first line studies looking at the agent with backbone of FOLFOX across GI tumor types in terms of safety. Interestingly, tucatinib has some interesting creatinine clearance issues with oxaliplatin. So it's not that it worsens kidney function, but it falsely causes the creatinine to go high. So as you move it to first line in combination with oxaliplatin-based regimens, that's something that is being studied in existing phase 1 studies to make sure there is no detriment. My personal take, I would worry about, let's say, an agent that causes a grade 5 event.
Right.
As in a first line setting where somebody could still derive benefit from chemotherapy, doublet or triplet with anti-VEGF. I just see this as one more option in the refractory setting right now. But TKI combinations that have relatively a more manageable side effect profile, again, this is just based on side effect. I think efficacy, both drugs are pretty efficacious, and the Mountaineer data will read out soon. The registrational study is almost at the tail end of its accrual. I see it just one more option, which is good.
Yep, I agree. Well, I don't see any other questions in the chat here. So
we already we took the liberty of being 15 minutes over since it's a social media platform. And again, both of us are available to continue some of this discussion online. Again, the platform from the Axiom, the goal is to have this recording available too, so we can continue some of the discussion online.
Great.
I just want to thank our GI panelists again for discussing these ASCO presentations and the implications to clinical practice. Thank you for the attendees as well. So I'm just going to wrap things up, and I hope to see all the attendees and including the panelists. Please tune in tomorrow for our next post-ASCO town hall, where we're discussing lung cancer studies from recent ASCO.
Thank you, Dan. It's always
Thanks,
nice
everyone.
to have a discussion with you.